Right, good morning and welcome to today's session at the Healthcare World Festival. Been a fantastic festival so far. We've had some brilliant sessions talking about infrastructure, talking about digital health, and today is the turn of our session on aid funding and the effects of current circumstances on aid funding, the effect of the alliance between aid and trade on the healthcare of sub-Saharan Africa, and on how we see this particularly important section of healthcare in Africa developing going forwards. Our chair today is former UK Health Secretary Stephen Dorrell. I am Steve Gardner, I'm the Managing Director of Healthcare World, but I've got very little else to add to this. I'll hand you straight over to Stephen. Stephen.
Steve, thank you very much, and thank you for the invitation to come and discuss the links between health and aid and trade, and the challenge that we face as a global community, looking at the continued development and restarting the development of the world economy, and particularly the health economy, as we look beyond the immediate COVID crisis. It's a phrase I try to avoid, is talking about post-COVID, because one of the core bits of learning, I think, around the whole COVID experience is that the world won't go back to a pre-COVID normal. We're needing to live with the impact of the virus on communities all around the world, and it's part of the challenge of thinking about the future of health and the future of development and the future role of aid and trade in economies around the world, is to think about how each of those individual elements impact in the changes that are going to be necessary as we think about living with COVID. Seems to me a more realistic and a more accurate, actually, way of thinking about the policy and practice challenges that we all face. So I'm delighted to be here and to be asked to chair this session on a vitally important theme. And what I'm going to do is to go round the glittering panel that are surrounding me on the screen in front of me and ask each of them to introduce themselves. And I'm going, if I may, to go around the panel in the order in which they appear on my screen, so that I make certain that we that everyone gets the opportunity to introduce themselves and their role in this very important subject. So I'm going to go first, if I may, to Asma Abiola and ask her to introduce herself, and then I'm going to go to her colleague Shola Dele Alua, both from the Clinton Health Access Initiative. So Asma first, please.
Good morning, everyone. Thank you, Stephen. My name is Asma Abiola, and I'm an associate at the Clinton Health Access Initiative. I work on our sustainable health financing program in Nigeria.
Thank you, Asma. Then to Shola.
Hi, everyone. I'm Shola Dele Alua. I'm a public health physician and the deputy director of the Vaccines and Primary Health Care Program at the Clinton Health Access Initiative based in Nigeria. I work providing technical and advisory support to the government of Nigeria on vaccines and primary healthcare system strengthening. Thank you.
Thank you very much, Shola. Can I go next to Lucy, please? Lucy Palmer.
Yes. Hi, I'm Lucy Palmer. I'm the Technical Director for Global Health in Mott MacDonald, which is a managing consulting company. We do a lot of work on health system strengthening, technical assistance. Currently, the project principal of the Better Health Programme in South Africa, which is one of the prosperity programs there. Thank you.
Thank you, Lucy. And then Mwenya Kasonda, please. Would you like to introduce yourself?
Thanks, Steve. Good morning, colleagues. It's lovely to be here. So my name is Dr. Mwenya Kasonde, and my background is emergency and trauma medicine, but I have transitioned now into a role as an independent global health consultant with a specific interest in private sector engagement in health and healthcare partnerships. Thanks.
Thank you, Mwenya. And then Rebecca Kiptui, please.
I think it's good morning. According to GMT, here it's good afternoon. Colleagues, my name is Dr. Rebecca Kiptui. I'm a medical doctor with a public, specialized in public health. I'm currently the head of the Universal Health Coverage Secretariat at the Ministry of Health in Kenya. Thank you.
Thank you, Rebecca. It's still morning here, you're right, but good afternoon to you. And then Jed Byrne from Health Education England, please.
Good morning, all. Good morning, Stephen. Good morning and good afternoon. My name's Jed Byrne. I'm a practicing surgical oncologist, but also the Global Director at Health Education England, which is the executive arm's length body of the National Health Service in the UK, responsible for workforce. My unit hosts the Better Health Programme, to which Lucy referred to before, and also hosts and I co-chair the Uganda UK, the Kenya UK, and Myanmar UK Health Alliances. Good morning.
Good morning. Good morning, one and all. So I'd like, if I may, to begin by just reflecting on and asking each of you to reflect on the role that official development assistance, government aid, is currently playing in the precise context of developing the policy response in the countries that you're most familiar with to COVID, because we've seen on televisions, there's a tendency in Britain at the moment to think that the worst is past, and probably in the very narrow sense of the British experience, it's probably true that the worst is past, partly because of vaccines. We'll come on to vaccines in a moment. Let's deal with that as a discrete subject. But around the rest of the world, most obviously in India, but not represented in this call, but I think it'd be interesting to hear what is the current experience, what it feels like to people living and working in Africa in terms of the policy response to COVID, and the role that aid programs are playing in that policy response, and the structure of those aid programs. Because one of the issues that I'm familiar with from aid funding of healthcare programs is short-term response, the difficulty of thinking through long-term program development. So from the perspectives that you're working in Africa currently, how does it feel, how effectively are aid programs coming from multilateral agencies or indeed from individual national governments such as the UK government? How effectively is that supporting the policy response to COVID within the countries in which you're working? And perhaps I can go first, if I may, to Nigeria and to Dr. Shola Alowa in Nigeria. Shola, how does it feel to you currently?
Yeah, thanks, Stephen. So the global response is what's happening in Nigeria is similar to what's happening across other countries. There has been a lot of donor support for the response to COVID, but health generally, because donor funding accounts for significant progress that we've seen in the health space in Nigeria, and contributes, even though it's a very important and critical part of health system support, it still accounts for less than 10% of the total health expenditure in Nigeria, the bulk of which comes from out of pocket expenses. However, with COVID, the very dramatic response and the swift response, especially with support for the COVID vaccine rollout and the initial diagnostics that we've received, the country has received from different donors across the world, has been really significant and has played a key role in, ensuring that testing in the early phases, but as well as the vaccine rollout that has happened now, especially with the Gavi, the support of Gavi for both vaccine procurement as well as early parts of the vaccine program planning. So it's really critical and has been a key part of the country's response. But, if you think about it in terms of the overall economic impact, because people still pay quite a lot out of pocket, it's difficult at this point to say how much of an impact that if you compare the out-of-pocket expenditure versus the donor support that the country has received. But overall, these intensified efforts we've seen underscores the need for countries like Nigeria to do more with domestic resource mobilization, especially as donor funding dwindles with the global situation. Countries are also focusing on their own, donor countries are focusing on their context, and countries like Nigeria are trying to do more to increase domestic resources for pandemic situations like this.
Okay. Thank you very much, Shola. Mwenya, you are working in a different country, but facing presumably similar challenges. If you're looking at from a Zambian perspective, how does it feel to you in terms of the availability of the resources necessary to put effective public health measures in place?
Thanks, Steve, for the question. So if you don't mind, I'm not going to talk about COVID.
Okay.
Not just because we're all tired of talking about it, but I just think that we're really addressing obviously a very important issue. And I think it's an issue that really goes far beyond COVID. I always think in order for us to address all of our healthcare systems during and after COVID, we have to first think about what the systems were like before COVID. And of course, there's a lot of difference across the world in what the baseline situation was in terms of maturity of different healthcare systems. And to speak to your question relating this to aid has an important role to play. Of course, we don't reject it. I don't reject it completely. But I do have, of course, some concerns around aid. Aid is simply not sustainable. I think specifically for us, for example, in Zambia at the moment, our healthcare sector is about 50% donor funded. We've not at all achieved, the magic Abuja 15. And I think in order to transition out of this more sustainable, more self-reliance method of healthcare systems, we really need a very clear roadmap as to how we're going to do so. Ghana has recently released a Ghana Beyond AIDS strategy, and I'm personally encouraging all African countries, or indeed all lower middle income countries, to follow that path on releasing a very clear strategy of how they plan to transition beyond AIDS. Dambisa Moyo, who's also from Zambia, wrote in her famous book that despite $1 trillion in aid flowing to Africa in past decades, real per capita income on the continent has really not improved since the 1970s. So who is benefiting from all of this aid? There must be surely something good coming out of it. Well, of course, we all realize, Steve, that the majority of donor funds actually stay in donor states, and that's really why it's not sustainable for us as a continent. Studies have shown, in fact, that for every $1 of US of aid coming into the continent from the US, on average, this increases EU exports by $2.6. So more aid funding to the African continent actually improves donor exports. How do we address this issue? Well, of course, the government has a key role to play, and I look forward to continue on this conversation throughout the hour that we'll be together. I also think the private sector has a key role to play. Multilaterals, as you mentioned, have a key role to play. Let's not forget civil society. Let's not forget research and academic networks. I think everybody really has to be engaged in this very important discussion, and eventually in the solution to this. Thanks, Steve.
Mwenya, can I come back to you, because I think at one level, it's a really good challenge to understand that the thinking about the shape of healthcare funding looking forward beyond COVID, and you're suggesting beyond aid as well, in order that it becomes self-sustaining and part of a growing economy in the continent of Africa. What if you were representing the Zambian government in a discussion with a Western government currently? What would you say would be the policy priorities from a health perspective in shaping the relationship between the Zambian government and the American or the EU or the British government?
Thanks. So the first thing for me to say is that we really must not underestimate our achievements, specifically as a country and as a continent. Africa is still known as a dark continent. We're still known for the many challenges that we face, but Africa has really come a long way and has done great things in many different areas, which for me is very important that we acknowledge and that we celebrate. Going back to your question of the Zambian government, the government of Zambia recently operationalized the National Health Insurance Scheme after implementing the National Health Insurance Act No. 2 of 2018. Since the implementation of the National Health Insurance Scheme in Zambia, about 30% of the population has been enrolled, which is really a fantastic achievement. And that's where really the way in which the direction in which the government needs to continue to move into. Again, to speak more specifically to your question on what else the government can do. Well, I would suggest number one, stimulating and encouraging private sector engagement in health. And this goes beyond the pharmaceutical industry. You've mentioned India, and I look forward again to more views on this, but the Indian example is very interesting to me because India and Africa overall has very similarities in terms of their healthcare systems. And the country of India, we know, contributes a great deal to African health system, specifically in the private sector, not just in pharmaceuticals, but beyond. And I also think we need to address this across the entire health system supply chain. This includes private education in health, it includes private health insurance, it includes private health service provision with a focus on primary health care and the rest. Other things that the government can do is improve procurement processes. I know specifically, again, with Zambia, we have many challenges with regards to the way that medical, not just medicines, but all medical utilities are procured. We need to improve the management of our debt, specifically our drug debt. Again, this is something that the Zambian government specifically struggles with, is drug debt within the Ministry of Health. And of course, we need to improve the entire system, so addressing issues around human resources for health and others. Thanks, Steve.
I think we've got quite an agenda of issues there, but we'll come back to, if we may, one by one. We clearly need to get into the vaccines and the pharmaceutical questions, but before we go there, I'm going to go to Lucy Palmer next, because when you emphasised the role of private sector investment in healthcare, and that's an issue which Mott MacDonald has a particular interest and point of view, I think. I'd be interested in how you respond.
Yeah, thanks. And although, yeah, I mean, I come from the part of Mott MacDonald where we actually do work in the international development side. So we also have a side which is more on the sort of engineering and healthcare investment. But I think I'll start with the sort of health system side, because I think I agree with it, a lot of that that's been said, that this is really, it's about building systems for sustainability. It's not about trying to encourage dependency. And there's been some very interesting things written about, the trouble with aid, Jonathan Glennie's book about sort of exactly the points Moenia was making. I think I would like to think that our approach, is not always perfect, but, that we have tried to always do projects which do keep the governments in the driving seat, which try to align what donors are funding with government-led plans, because otherwise, the under-resourced health ministries get, very overwhelmed with different, funders coming in, trying to run their own shows and funding different fragmented parts. So, I think where aid has been done more successfully, it is with that real close engagement with ministries of health. And interesting that I was also going to bring up the Ghana example, because I think that is a good example in 25 years of a country that has progressed, from low income to low middle and has the Beyond Aid strategy. And interesting, there's in fact just a paper being written at the moment, sort of looking at that. And interestingly, like some of the UK investment in that was, I think some of the part that was really successful was where there were more sort of pooled funding, where there was sector-wide approaches so that there was more sort of alignment, more clarity, and that I think did allow the government of Ghana to have more, becomes more institutionalized and sustainable. So, there's lots of things to talk about, but, possibly the last few years, this move towards donors really becoming more wanting their own results, attribution, wanting their own results. So instead of this sort of more shared vision, that's probably been, slightly moved away from some of these benefits. But yeah, I think with the investment, there's clearly huge areas. And one bit which is interesting from a Mott MacDonald point of view, is a part of the business I know less well, but in India, obviously having huge troubles. We have a small unit which is helping one of India's vaccine manufacturers set up its manufacturing plant for the active ingredient. This is Zydus Cadila, based in Ahmedabad. And I think these are really fundamental. I think the only way, to help through this is for this sort of support on the ground. I mean, increasing capacity, probably looking at some of the initiatives coming out of helping to, waive intellectual property, if that's what it takes, some of those issues. So, yeah, I think it's, so much to be done, but great that, if the public and private sectors work together. Thank you.
Thank you very much, Lucy. When we did introductions at the beginning of the call, I think I'm right in saying Isabella Minor wasn't actually on the call at that time. So, Isabella, could I ask you to come in and to introduce yourself, and also to respond to perhaps to some of the points that Mwenya was making? Is that going to work, or Isabella is remaining on mute, so I think oh no, she's here.
Hello everyone, Isabella Maina is my name, from the Ministry of Health, Kenya. I just joined in late, I'm sorry for that, but as a country, we are also working on sustainability. As you may know, Kenya is a lower middle income country with a devolved system of governance, with quite a lot of priorities on UHC, strengthening the health system. So right now we are working on a roadmap to sustainability. Chair, if you would allow, I don't know whether I can project maybe 2 or 3 slides to just give an insight of where we are in Kenya.
That would be, of course, of great interest. Yes, please.
So just to show where we are on the landscape of health financing, that's the outline of the presentation. Very quickly, to show the kind of financing that we have. The lower bottom with blue is government funding over the years. What is in orange in the middle is household, and what is gray is private, and what is yellow on the top is donor funding. So what this graph is showing us, or the bar chart is showing us, that the government funding in health has been increasing over time. But however, we still have a lot of work to do, especially to work on this area, the orange, where 31% of the funding is out of pocket. This is data for 2015-2016. We have now done a survey, though it is not published yet, where we have seen the out of pocket has reduced to about 20-something, about 20%, which is a very good progress, while the government funding to health has been increasing. Probably in the next meeting, we'll be able to share that survey, but this is the landscape. Our issue is to move towards UHC to ensure that 31% goes down to maybe 20%. This is a scenario of pre and post devolution. For those who do not know, we are in a devolved system of governance where Kenya have 47 counties and 1 national government. Each of those counties are an independent government with a health system, with a county health system, and then 1 national health system. So quickly, this shows that before devolution, the first 2 charts are showing the financing before devolution right in 2013. But if you look at the line graph, it shows that we have been increasing the financing to health. for both counties and the national government. So the green is the county funding, while the orange is the national government funding. And then we have percentage of the total government allocation to health, the 8.2%. Some trends in health indicators, the total health expenditure per capita is about 78.6. I think against US of about 86%. I don't remember the figure very well, but 78 not so bad. It's been increasing. The total health expenditure as percentage of GDP, the red one is about 5.2%. Right now, I think we've gone to about 5.5%. This is 2016 data. And the government health expenditure as a percentage of the total health budget is about 6.7%. And I heard Mwenya talking about moving towards Abuja declaration of 15%, but really there is progress towards this. Health insurance market quite slow in Kenya. I'll just focus on one figure here, that's only about 19.1% of Kenyans have a form of health insurance, and majority of those 17% are covered by the National Health Insurance Fund. Therefore, with that scenario, bearing in mind that Kenya is a lower middle income country with donor transitioning, the fact that we have COVID, we know what it has done to the health systems globally. So what do we want as Kenya? We have the UHC agenda, and we have our colleague Rebecca who will maybe be sharing insights on what we are doing on UHC, but very quickly just give some priorities that are critical, in the health system, even as we invest in UHC, even as we tackle the issue of COVID. It is investment in health system areas, the human resource, the equipment, commodities, including vaccines, health information system, having a good referral system, investing in ICT, investing in primary healthcare, and our colleague will talk about that, communication, M&E, and investment in leadership. But coming close home to health financing, the government is hell-bent on increasing public spending on health to international or recommended targets. And right now we are working on transitioning roadmap and seeing how we work towards this together with the National Treasury, mobilizing domestic resources to ensure sustainability. And I've already said we are working on transitioning plan, expanding health insurance. Right now we are talking of having a law to mandate health insurance in the country, while still focusing on protecting the poor and the vulnerable groups. And I think our colleague from UHC will talk about that. Then, as said by the other colleagues, explore alternative financing mechanism, including using of public-private partnership. And of course, with the little resources we have, it is ingraining efficiency in utilization of resources. And we have a roadmap of, having efficiencies within the health system, at the county level, at the facility level, procurement, and all those issues. And now also in terms of efficiency, aligning spending to address the health outcomes so that it's not just input financing, we are looking at the outputs that we produce with the kind of financing that we have. So Chair, thank you very much. That's what I have as an insight from Kenya, but we have our colleague on board who may add a little more on what we are doing on UHC. Thank you, Chair.
Thank you very much, Isabella. I think the colleague you're referring to is Rebecca Kiptui. Is Rebecca?
Yes.
Yes, sir.
Oh, yes,
Yeah.
Rebecca, would you like to add to what Isabella has said?
Yes, I would like to add to what Isabella has said, and on top of that, I would like to give some responses to what Mwenya had said. Very interesting points, Mwenya, and very valid. So, what she talked about especially is about the issue of primary healthcare, which is currently a priority for the Kenyan government to strengthen primary healthcare, and which is part of our actual UHC agenda. And I just as Isabella had asked to share. I was asking to share. I just want to show us the journey that we are going to go through, and also address some things that Wenya had actually talked about. This for me is just going to be one slide so that you can see. If I'm allowed to share.
Yes, please. Of course.
Let me see. Share screen. I hope everybody's able to see this screen.
That's good. That works.
That works. Good.
Yeah.
So this is just our UHC journey so far. We started seriously looking at the UHC journey sometime in 2018, where we had phase 1 of our journey. We had pilots, counties, around 4 of them participating in the pilot, just to have a feel how we can actually attain UHC. The main focus there was generally on input financing, so strengthening the systems, putting in human resource, putting in medicines, pharmaceuticals, putting in human resources for health, and then also strengthening the primary health care facilities with basic equipment. So that went on for about a year. And at that point, the services were all free. And what we realized that this is not a sustainable way of trying to do things, but we say the system still have to be strengthened, especially at the primary healthcare level. 1, to make sure that there's access to the healthcare services at the nearest access point for the citizen, and then to ensure that the higher level health facilities are not overwhelmed with the number of people that will come, that will go straight to the higher health facilities, because people perceive that the higher level the facility is, the better the service. So strengthening those ones. So what we did, we rolled out that to the rest of the counties, the rest of the devolved functions. Again, there was an inputs of human resources, medicines, basic equipment. And we also thought of organizing the primary health facilities into the primary care networks, where you have a referral center, and then you have the lower facilities in that particular referral center within the catchment area, actually moving together as one, as a network, so the resources within those networks could actually be shared. We then looked again at the issues of sustainability, and we said now we have to move from the input financing, putting just only inputs, to now output financing, looking at issues to do with actually financing health based on particular outcomes or outputs, and therefore transitioning into a kind of a social health insurance, which we are currently in. We're transiting from input to output. Therefore, we have said as a government, we'll now start looking at the indigents first, the poorest of the poor, first of all. So the government has put aside some provisions for I think it's around 25% of the indigents so far, who will be able to access a benefits package from our national health insurer. At the same time, we are still continuing with the strengthening of the primary healthcare services. Our long-term goal would be going fully into social health insurance, just as Isabella had said. And I think this for us is very, very important, because during the COVID period really taught us a lot of things, because everybody was grappling with the COVID issue. Most countries were now looking inwards and trying to help themselves first before helping others outwards. So I think as African countries, we have to prepare ourselves and think about how can we be more self-sufficient than being dependent. So that is one thing that we really learned during the COVID issue. The other issue is, during the strengthening of the primary healthcare services, we actually managed to do training of community health workers at the community areas using the UHC funds that were available, which is 100% government. And those same CHVs were used to give home care to patients who do not have severe COVID symptoms. So we're able to have done home care with those particular community health volunteers. And for us, that really helped. And I think the lesson is, if we have strengthened primary healthcare systems, whatever shocks that might come, Like, for example, a COVID pandemic, as it has been, with the health system will be resilient enough to take those shocks. Again, if aid is available, I think it would be very prudent for us to use the aids that is given to us to build systems that will last. So that even once the aid has stopped, there is something that has been left behind to continue strengthening that particular system. Another thing that we have learned very well during the COVID, and which is again pointing towards UHC, is the issue of partnerships. We set up a very strong partnership, and we had a national emergency response committee made of everybody, partners, both multilateral, unilateral partners, and together we managed to build up a response. Of course, with the Ministry of Health in the driver's seat. I think Lucy had talked about that. So that really helped. And also the fact that some especially donor agencies like the Global Fund, which usually just funds malaria, TB, and HIV, actually having additional funds to look into the issues to do with COVID. So that also really helped. So I think that is what I would like to submit. Thank you so much for the opportunity, Chair.
Thank you very much, Rebecca. It is a very strong message from both Isabella and Rebecca from Kenya about the commitment to develop a universal healthcare system in Kenya, which I'm sure is reflected in other countries on the call as well. We might come back to that. But Asma has got her hand up. So Asma, please, the Kenyan perspective has prompted a response.
Hello, everyone, again. It's been great to hear from all the other countries. And I think the one thing that stood out is sustainable financing mechanisms. But then even before that, just building off of what Shola had mentioned about the COVID response in Nigeria, I think something that the country did quite well was leading the process. So we were very quick to establish a presidential task force for COVID-19. And we saw a lot of organization around the private sector and also donors as well. So it was a very collaborative process, which also had us thinking about what an effective transition could look like. So while yes, donor funding long-term is not sustainable, we also know that a very abrupt transition isn't helpful either. So seeing what that could potentially look like and seeing that there are some lessons that we could learn from how the COVID-19 response was organized is also very beneficial and something that we hope to learn from and something that we hope to use going forward. Another thing is also just how much we were able to do in terms of the essential service continuity in country. We have a lot of initiatives that we are working through, as we're also using donor funding to create structures that just build confidence of the private sector. So we have, we're now trying to move from voluntary health insurance to mandatory health insurance. Nigeria has a population of about 200 million people, and we only have health insurance coverage for about 10%, less than 10%, most of which are in the formal sector. If you then look at that in comparison to the fact that at least half of Nigerians live below the poverty line of 190 a day, then it creates an imbalance that we don't want to see long term. So the fact that the government is thinking of ways to transform policy into implementation and also learning lessons from the COVID-19 response and how we're able to mobilize resources is something that I think that most countries can learn from, especially from this side of the world as well. So just trying to synthesize that piece of, okay, yes, donor funding is not sustainable long-term, but also we need it to kind of establish the systems that we will then use longer term to fully transition and also mobilize resources that we need longer term. So just pointing that out. But very interesting conversation, thank you.
It's really interesting to me that a strong theme coming out of this conversation is healthcare beyond aid, proposition 1, but proposition 2, that there is a commitment very strong from Kenya, but it's a World Health Organization goal, it's the UN development goal, the development of policies for universal healthcare. And so beyond aid, into universal healthcare and what is the role of the respective roles of the public and private sector in that? Is it all on the Western tax-funded model, or is there a co-funding model to deliver universal healthcare? Seems to me one of the absolutely fundamental policy choices that underlies quite a lot of this conversation as it's developing. I don't know whether you'd like to comment on that, Asma, or it's what that looks like from a Nigerian perspective.
So I think, first of all, if we look at what COVID has shown us, I think COVID has shown us that public health is a global good. So if there's anything that we've taken from it, is that we're all affected by the poor health outcomes in any country, or we can all be affected by the poor health outcomes in any country. So going back to your point about universal health coverage is about equity, right? And we know that to achieve that equity, we do have to redistribute resources from people that can pay versus people that can't. Now, does that necessarily have to be a national effort, or is it okay for it to also be international, especially when you look at how COVID has affected everybody? So I feel like it can be a mix of methods, right? Because if there's something, again, just going back to COVID, because I feel like there's so many lessons that we've taken from COVID, is that it's a global bad for us to be in a poor public health situation. And if we all take a global responsibility at the national level, at the international level, whoever can pay should pay to some extent. I'm not saying that countries should not take individual responsibility for their healthcare systems, but I think that if we look at one, most countries do want to take that responsibility, but then there's also the question of if they can afford it. So would we rather just say, okay, everyone should take responsibility, or should we try to develop models that are more co-funded, are more collaborative, where everybody chips in as much as they can and we all win at the end of the day? So to answer your question, I would say a co-funding mechanism where everybody contributes as much as they can, given that we all have a stake, is how I would answer that.
And it's interesting that you picked up the phrase or the word co-funding, and as a choice between national and international funding, which I think is one response. It's also, of course, a question within individual societies. And I'm going to your colleague Shola's got her hand up. I'll come to her next, and then I'm going to go back to Mwenya actually to ask about the within country, the public-private balance of the funding of sustainable universal healthcare. But Shola first.
Yes, thanks. And I think just to add to this is we need to be aware of the macroeconomic situation of developing countries that may not always be the best proxy indicator for eligibility for aid, or transitioning out of aid. For using the Nigerian example, that has a higher GDP per capita than the average sub-Saharan African country, but still has some of the weakest health sector and financing indicators in the region. And so it's not always about the functionality of the macroeconomy. Sometimes, lots of times more nuanced than this, and how the health sector and economy is organized and prioritized. And so bringing back to this comment about co-funding, if we look at the Gavi transition process in Nigeria, for instance, Gavi supports the vaccines program, and there's currently a 10-year transition plan so that the country is able to slowly increase its co-financing and its ability to pay for the program itself, while Gavi slowly transitions out. So really reiterating that point that while we need those sustainable systems ourselves, the transition process needs to be a bit more realistic for countries to be able to absorb the finances themselves.
Thank you. So I'm getting hands up everywhere, and I'm conscious there's two gentlemen on the call that I haven't yet brought in. So I did promise to go back to Mwenya, because I thought that you might have a view on this the co-funding question. Then I'm going to go to Jed Byrne, if I may, from Health Education England. But Mwenya first.
Thank you. And indeed, this is a very interesting discussion. And I realize that the clock is ticking. I wish we had longer. So I'm going to go back just for a minute on my private sector engagement. And I'm in as much as I'm very much a proponent of the private sector, as you've realized by now. Of course, it also has its deficiencies and issues. The private sector specifically is very curative. You know, the model of care tends to lean around the curative patient treatment type of model, as opposed to being preventative. I think really in order to achieve what it is, what we're trying to achieve, which at the end is universal health coverage, you may define our ultimate goal as the sustainable development goals, but really we're trying to build here a comprehensive health system that is preventative, curative, rehabilitative, and indeed palliative as well. And the critical issue here is whether African governments are going to be able to negotiate agreements with the private sector, or indeed with whether they be government-to-government agreements or others, that can enable that medical access across the entire continuum of care for both the rich and for the poor. I think to bring back India into the conversation is a very interesting position, as we all know, because India is at the center of the global vaccine manufacturing for COVID-19. But of course, it's also at the center of a new wave, of COVID. So lastly, I think Asma raised a very important point around equity. I think that also needs to be considered in all things. There's so many things here to consider, but I think equity as well needs to be mentioned very strongly, because indeed universal health coverage ultimately is about equity. In order to achieve equity, the head of the WHO always says you cannot improve what you cannot measure. So we're going to have to work towards measuring equity. That involves data. Of course, all of our decisions have to be data-driven. Disaggregated data is going to be key for all of this. So I'll stop there, Stephen. I'll let the other two gentlemen speak as well. Thanks.
Thank you very much. Jed's been extremely patient. So Health Education England is I guess the challenge for Health Education England is to be both a learner as well as an educator, but also to ensure that it fits in an African context. It's led by Africa, not as the solution provider, as it were.
Yeah, thanks, Stephen. I'm rather glad, actually, that I've not been brought into this point, because the conversation's been so rich. I've written copious notes, and it's actually difficult to crystallize what I'm thinking at the moment. But I'll just say the following. I am fortunate to be sitting in a country which has the oldest and largest universal health coverage system in history. We are, as I'm sure, clearly present company excluded, it's been led variably. We've made every mistake under the sun, and very often we've made progress on the basis of those mistakes. We have also relied, although very often not shouted from the rooftops, on human resource partnerships with various places across the world. It's been absolutely crucial for us. My worry about the conversation about aid is when I'm not by background a manager, I'm by background a clinician, but I was always taught management for dummies. And I was always told that when you were developing a new start or an SME, you started with vision, went through function, then went through form, and then worked out where your finances were going to be. And I think there is a risk, and I think several of the speakers have already said, there is a risk of us losing the vision here, and therefore not spending money that we have in a pooled way on a common good. And I think, I was really reflecting when Mwenya spoke about what has been achieved in Africa. I mean, certainly my personal experience, probably the country I've worked in longest is in Uganda, and I've watched the north of Uganda go from a post-conflict zone some 15 years ago, develop at a GDP increase of about 10 to 12% a year, and go as a region really from the lowest of low-income countries into a transitioning economy in the space of 15 years. And I know that model has been reproduced in many different countries within Africa per se. I think the discourse which is most important for us as the NHS is one of mutually beneficial partnership. And I think that the key to sustainable health system strengthening ultimately is demonstrable ethical mutual benefit. And irrespective of how we fund that, providing we have a common vision and a partnership and the right informal and formal peer-to-peer relationships, the funding that we do have will be maximised and used to its best effect in terms of the common goal of universal health coverage. In terms of COVID per se, and I know this was your original question, Stephen, I don't know what impact COVID will have on our existing relationships. My unit is currently working in 25 countries, 9 of which are part of the Better Health Programme. We're being asked to work in different countries all the time. Many of that, we've been in constant touch with all of our partners internationally, and they've all had very different experiences. We're doing some work in Brazil at the moment, which has been hit very badly. We have a lot of work, both regionally and nationally, in India, working on health system strengthening, and likewise, they are going through a really devastating period of time at the moment. And I don't know how things will emerge, but what I do know is that one of perhaps the big solution to global health security and global public health moving forward is partnership. And that partnership is predicated on people, and it's predicated on relationship. So I think whilst finance is clearly very, very important, I think we are going to get best value for money when that we have a shared vision and relationships which will allow that money to be spent appropriately for mutual benefit.
Jed, thank you very much. I wholeheartedly agree with that. Lucy's got her hand up. Before I come to you, Lucy, can I bring Francis Omaswama into the conversation? Francis, we'd started by the time you arrived, so would you mind just introducing yourself? And we look forward to your contribution.
Good morning or good afternoon in some places like here. I joined late because the first link I had didn't bring me to the conference, but here I am, and I think I didn't join too late. It's great to have this panel with the majority of ladies in it for a change, and that is the future. Okay. I am the Executive Director of the African Center for Global Health and Social Transformation, which is a think tank, which is envisioning to make Africa a better player in global health, to benefit more, but also to contribute more. And I come from a background of mainly health services management. I was Director General in the Ministry of Health here in Uganda. And I also served as the founding Executive Director of the Global Health Workforce Alliance at WHO headquarters. And I have had hands-on trying to support better access of healthcare to the poor. Now, I also have with me listening in here, Dr. Patrick Kadama. He's a health economist and has been my advisor and expert on this topic for a long time. He was the head of planning when I was the Director General. And then he went to WHO headquarters where he was an anchor in the health system cluster there for very many years. We are both retired and working here in this place. Okay, very briefly. What would we like to contribute to the topic? In my experience here in Uganda and in the African region, the biggest challenge we have to financing healthcare is the backlog from a historical situation where health was classified as a non-productive sector. And because of that, the social goal of making health a priority, despite the effects of issues like COVID and all those pandemics, this attitude has not gone away. The head of state in Uganda is more interested in building roads. He basically tells us, wait until the economy grows and we will put more money into the health sector. We will have more money to put into the health sector. The population growth rate is high, one of the highest in the African continent, and the expenditure per capita has been declining over the last so many years. When we were in the Ministry of Health, it was about $65. Now it's about $43. So with that, the health services are in big trouble. And despite a lot of noise during political elections, health is very important, but when it comes to budgeting, it is nowhere. In fact, this year, the budget is being decided now, the health budget has been cut. So that is my contribution. How can the international community change that mindset? I met with Sir Paul Collier, who was one of the leading economists. He's a professor in Oxford. He admitted in a meeting in Germany 2 years ago that they made the mistake of teaching wrong economics for the last 40 years. And it is now time to unlearn that teaching, to unteach that teaching. And we've been asking for those people who did the teaching to come and unteach, but they have not come. I'm really talking about IMF, the World Bank, and some of those liberal economic people. So that is really my message. If we are going to get over this problem, let's put health as the key priority, the purpose of all SDGs that it actually is, through convincing our leaders that this is the way to go forward. All of us together, we here in Africa, and then you, our partners abroad. Dr. Kadama has another angle, which if you allow, he can contribute in just a minute or so. Is that okay?
Of course. No, another angle we are always, we should always be interested.
And it is not very different from what I've heard. My name is Patrick Kadam. And the point is, if you watch the power dynamics between multinational corporates and what we call multinational intergovernment agencies, some people call it the Davos discussion, as opposed to the UN level discussions and why the World Health Assembly is preceded by the Davos meeting or the executive board in January, and how that has shifted the thinking towards a development model that was developed soon after the Industrial Revolution in Europe. We have not yet fully transitioned from that to a common view about social aspirations to drive development. We are still in the transitional period of where UK was when they developed the National Health Service, which they have not also fully gone over. And until we get to the position, especially in the developing world, that investment in human capital is going to drive more sustainable social transformation and infrastructure, instead of the other way around, that if we build infrastructure for the rich, they will nurture social transformation. We shall not get over this. And this is the dilemma that we have found ourselves in trying to roll out health insurance programs on a model that is from a development paradigm of the last century, at the beginning of the last century. And we are going to get more and more difficulties on this. This is a lesson that our leaders, we shall have to continue to work on that our, let's call it the development society, will have to begin to sort out on how we at Davos interact with the common social goals that are embodied in the structures that you reached after the Second World War, and which are beginning to be pushed off the table, and how we get that to benefit everybody. If we do not have better justice and better, more equitable social services or outcomes will not be able to move away from a development aid that is merely a key or a leverage for corporate power to grow. That's where we are with the international aid at present. It is merely a key for corporate power, especially in the development world. And what happened with COVID is very clear. Onset of COVID, we were almost equal, but those who had advantage through WTO, through TRIPS agreements, got out quickly to sell as a product. That is now being rolled out. And that discussion should have been different. We should have had the discussion on waivers before the rollout of the vaccines. Thank you very much.
Thank you very much.
Sorry for bringing in an additional contributor, but that is our message to the meeting. Thank you very much for listening to us.
Thank you, Francis. Thank you, and to your colleague as well for you've certainly made a contribution which has prompted some hands to go up. So what I'm going to do is, if I may, go to Lucy Palmer first, because I think her hand was first, and then to Rebecca, and then to Mwenya. So Lucy.
Yeah, thank you. Would just thoroughly agree about the sort of thinking about this in terms of people and the impact on that, and that we don't need to justify investment in health, whether it's going to have an economic impact. It's important in its own right, as where it's we're really looking the other way around at sort of infrastructure projects. What is their impact on people and social outcomes, and seeing the failing. So I really agree. I just wanted to raise the issue of quality of services, because I think this is really the whole work done by the the Lancet Commission on high quality health systems has been, I think, really good body of work showing how there's a lot of sort of wastage in current health systems worldwide, especially where the less advantaged people have got access to the worst care, and there's really more deaths, I think, we've now shown to result from poor quality care than from non-access, non-utilization of services for conditions that are amenable to healthcare. So I think that's a huge finding. And also I think some of the aid, typical money, there's a lot that gets spent in a quite unfocused way on training, things that are sort of measured very much just in inputs, not enough focus on really performance and the accountability and what that means to the service to end users. And often the experience of the end user is missing from the metrics. And I really liked what the Lancet was suggesting, that we need better, fewer metrics. In my own view of a lot of aid, it's become overburdened by too complicated a system, too much data, which is sort of to service a machine, a beast, from the headquarter end, and not enough attention to really the just pure accountability of the service that the end user is getting, of the equity. So, I'd like to just raise that point. But I think also what Jed was saying about partnerships and sort of human capital, just a quick example, in the South Africa Better Health Programme, there's been a quite successful, just recent twinning agreement between the UK Parliamentary Health Service Ombud and the South Africa Office of Health Ombud. And I think this kind of partnership, which really does, trade experiences in how you allow quality mechanisms to work, in practice. I think, this is some of the things that I'm most proud of in that program, those kind of successes.
I couldn't agree more with that, the focus on health outcomes rather than inputs, and delivering quality and equitable distribution and access. Those are, they're more important than the process goals that sometimes David Nicholson used to say when he was chief executive of the health service, that we're good at hitting the target and missing the point, which I think is a very good way of encapsulating it. So Rebecca, your hand went up as well.
My hand went up actually when Jed was talking, and he really touched some strings. And again, it's about partnerships. The fact that he said ethical mutual benefit. And the other thing that he talked about is partnerships are based on relationships. And that is so important. Why is it important? Because we are human beings. and we don't live on an island. And for those ones who live on an island, they actually have to use modes of transport to reach out to others, because what is happening currently, and I think COVID has really taught us that, is that we are living in a global village. So something happens somewhere in one continent, and it can affect everybody around the globe. And I think that's what I just wanted to emphasize, the issue that partnerships are so important. And we need to reach out to one another to ensure that all of us can actually live healthy lives. So that's one thing that really touched my chord. The other thing that I wanted to say was also, and Lucy has already said it, it was a response from Asma, where she talked about UHC, or UHC being about equity. Yes, it's about equity. And I wanted to put in the issue of quality of care. And I think Lucy has brought it out very clearly that even though, yes, we'll have an affordable healthcare, it doesn't mean that if you're poorer, you should get poorer services. It should be the same services across the board, whether you are rich, whether you are poor, and therefore it's very, very important for all countries to ensure that their basic or their essential benefit package that they have put together is comprehensive enough to take care to take care of the people within their particular country, so they'll be able to access the comprehensive care that Manya was talking about, not just curative, but the whole of that. So it's very, very important to do a proper definition of the benefit package. And I remember during the COVID period, most insurance companies were not covering COVID patients because that was like an emergency kind of a thing. But now they had to start incorporating a package for COVID. So again, it's something that we should learn to always ensure that the benefits package is responsive to the needs of the people. Thank you very much.
Thank you, Rebecca, and thank you in particular for the emphasis you place on partnership, or the fact that we're a global village. It's not just the virus is something that doesn't respect borders, but also the proposition that the response to the virus is something that's a global interest. It's a shared interest across different countries of the world. I want to bring Wanya in, but I'd like to move the conversation on a bit, because I've been signaling more than once during the conversation a desire to just to reflect on the policy questions that are very current at the moment around vaccines and patent protection and access to vaccines. Because it's been blindingly obvious, hasn't it, from the beginning of the pandemic, that if there was going to be a vaccine, and in the early stages of the pandemic, it wasn't God-given that there was going to be a vaccine, but if we did, as we thankfully have done, develop a scientific response to this health threat, that it wasn't going to be available to 7 billion people on the same day. And there was going to be a rollout question and an access question brought into very sharp focus around the access to COVID vaccines. It, of course, raises broader questions around access to expensive patented medicines, in particular from an African perspective. And I'd be interested in, I'm going to ask Wenya, put you on the spot slightly, the extent to which you think that's an issue for now, and whether you agree with the approach that President Biden initiated last week of, as he would see it, easier access, and whether you think that's the right response, or whether there's a different response that for which you'd be the advocate.
Thanks, Steve. Before I address that question, if you don't mind, I just want to respond to the intervention that was brought to us from Dr. Francis and his colleague. And forgive me if I'm taking us in slightly different trains of thought, but I think some very important points were raised, which I'd like to also add to. First of all, I'm glad they brought up the Davos discussion. I have to say, I've never been to Davos, but I look forward to the day that I can fly in a private jet to attend a conference about poverty. And Dr. Francis really mentioned the importance of having to convince our governments about why healthcare is a worthwhile investment. And I want to take that a step further, if you don't mind, and just advocate for the investment in human resources for health specifically. And I explain the benefit of this investment through what I call the triple dividend. Number one is the health dividend. Millions of new jobs created in health and social care will meet a growing demand, respond to demographic changes, and assist to deliver universal health coverage. Secondly is the gender equality dividend. 70% of the global health and social workforce is female. Today, women are the main providers of care, including in health emergencies, humanitarian crisis, and in conflict settings. Therefore, investing in women and the education of girls to enter formal paid work, equally paid work, I might add, will increase gender equality and promote women's empowerment as women gain income, education, and autonomy. And thirdly, Stephen, is the development dividend. New jobs will fuel economic growth. Across all streams, the health ecosystem is playing an increasingly important role in inclusive economic growth and therefore sustainable development. So that's just my little addition there to what was mentioned by our colleagues from Uganda, and thanks to Dr. Francis and his team for those reflections. And then to come back now to your question addressing vaccines and vaccine equity, I think I said it before, for me, the importance here in all that we do is to make decisions that are data-driven and evidence-based. So even as we talk about equity, as we talk about vaccines, and as we talk about COVID, I really want to again encourage everything that we do to be based on the evidence and indeed on the data. And for me, disaggregation of data is just as important in order to guide those discussions. Back to you, Stephen.
Okay, yeah, thank you. Well, I very strongly agree. It's a favorite theme of mine, dating back to my time as a health minister, actually, that health is not a national overhead. It's not a cost on the economy. It's a contributor to the economy. It's a form of wealth creation. It's not a form of wealth consumption, as it's sometimes represented as being. And that's a core to an understanding of not just of sustainable health systems, but of sustainable economic growth. It's nonsense to say that it's sometimes you have to explain to people that making locks to put doors on to lock doors, nobody disputes that that's a form of economic wealth creation. But to make people healthier sometimes is said to be just that's the role of that in economic expansion, economic development is challenged, and I think it's nonsense. And I wholeheartedly agree with the view that the development of the health economy is part of economic development properly understood. And that's a theme that for which there should be a wider understanding. Does anybody else want to come in on this question of vaccine equity and the access to vaccines? I picked it up because I think, Shola, you mentioned it in your original introduction. So can I come to you, and then Jed's put his hand up on that question as well. So Shola.
Yes, it's just a clear example of some of the inequities in global health that we see. It's not, vaccines is just one example. Generally, health commodities, and even how support for health, the different health programs, where the priorities, some global health priorities may not always be context relevant for certain countries. So it's and just to echo what everyone else has said about the inequities that exist, I think the vaccine example clearly shows that developing countries and African countries really need to can't always be fully dependent on aid, as much as we need to prepare ourselves for the transitions that will come. The vaccine example is a very clear one. There is, like you had rightly said, there is no there is no way that everyone at once would have gotten the vaccines, but in the way it has been distributed, from those who are manufacturing to those who are receiving, if there was no Gavi alliance now to support developing countries, there would likely have been very limited access to and even with that, the availability of these vaccines is not, equitably distributed. But picking up Mwenya's point about evidence-based decision-making is a very, very important point. And most countries have the immunization advisory groups who are supporting decision-making for how much vaccines countries would need, and how well the vaccines will contribute to reducing disease burden in the different contexts. And I don't think that there is enough evidence across board to show just how much impact this is having across different contexts. And that's an area that really needs to be further researched.
I think we've lost Shola, unfortunately. You're back.
Okay. I don't know what the last thing you heard was, but I think leaving the vaccine points a little bit and back to this issue of aid effectiveness and transition, I think that countries in this part of the world really need to clearly define and structure how aid transition should work in a way that it allows effective planning and very importantly, limits shocks to the health sector. There's been a lot during this discourse about the critical relationships that exist and should be strengthened to allow for soft landing. We need sustainable systems, but we need to do it in a realistic and feasible manner. And aid transition has to be done in a way that prepares health systems to adapt and accommodate to these changes, especially with the question of equity, as has come up very, very clearly. And the approaches should be clearly defined and intentional to prepare countries for managing transition periods. This hasn't often been the case, and we hope that countries are able to do this more often, that donors, in those conversations, work with countries to define how transition should work and not just prescribe them to the countries that are receiving aid.
Okay, thank you, Shola. Jed and Isabella both got their hands up. So, Jed.
Okay, I'll try and be really quick. So, first of all, is so these are my own thoughts rather than any representative thoughts I may have. So, what I've observed in the UK is a move towards a political interpretation of evidence through to a scientific interpretation of evidence over a 15-month period. And that has had a significant impact in the way in which we've responded to this pandemic. And I think the interpretation of evidence is as important as the evidence itself, and who we ask to interpret it and what weight we give to that is also really important. And I'm an academic surgeon by background and recognize that data is what data is until it's interpreted. So I think that's really important. The second issue for me is a reflection on a real need for us to renew our relationships with the World Health Organization, because I think, I've been in touch with the workforce directors at Geneva and in Copenhagen, Copenhagen's European office and Geneva, on a weekly basis. And I think they've had a very difficult time over the course of the last 15 months. And a personal interpretation of that is that I don't think that the Western economies have really bought in to the power of a pan-global response in notion or in concept, really. Now, some of our Western colleagues have made this very clear. Fortunately, they are no longer holding the tiller in terms of contribution to the WHO, but I think it runs much more deeper to that. The underpinning principles of the COVAX program are robust, they're evidence-based, and they make complete sense. But think that one of the reasons why it has stuttered into impact is because of a lack of pre-existing buy-in from Western economies across the globe.
Yeah. Yes. Well, I agree with that. I might mention it now because it links to some of the focus that when you mentioned about the need to focus on outcomes. What is it that delivers? Where's the evidence about effective outcomes? And I think the reason Steve Gardner asked me to chair this discussion is that one of the things I've done since I left active politics is to chair an organization called Public Policy Projects, where we say we're an independent policy institute, but we have 3 clear points of view. We're in favor of an open internationalist approach to the world. We're in favor of a mixed economy, and we're in favor of building healthy local communities. And one of our next webinar is actually in the morning, tomorrow morning, when Sir Michael Marmot, who some of you may know as a global advocate of the importance of looking at health rather than just at healthcare, and looking at all the determinants of what the citizens' experience of health, where he's going to be talking to us about that and talking about it, interestingly, in a global context. We're being joined by another voice from another country. I can't, I'm afraid, remember. Oh, no, I can. It's from Italy. So the proposition that health is a shared interest across different communities and different countries, it's a global interest, is something that I regard as, if you haven't learned that after the COVID experience, I guess you never will. But can I go to Isabella and then to Francis, and then I fear we're running out of time, but Isabella first, please.
Okay, so thank you very much. I just want to touch on the issue of vaccine equity, quite important. No one is safe until all of us are safe. I think that statement has been said all over the world, that all of us have to be safe. And I really appreciate what the US did in the last 1 week. But I think we need to focus more on more issues. For example, in the low and middle income countries, what is the capacity? Do we have the necessary raw materials? Do we have the necessary business environment? Do we have the skills? So I think we need to go beyond the waiver and help countries to, to set up and even produce more. But even coming back to the low and middle income countries, I think also we have to focus inwards and look at how efficient are we with the resources that we have. What can we do, or what should we have done in the last 2 years? COVID hit us in 2020, early 2020. We are 1 year plus. How can we be more efficient and even plan better? For a long time in our countries, we've been talking about enhancing local manufacturing. For example, in Kenya, we have that as an agenda now. But have we moved forward on that? So I think the conversation is beyond just looking at the West to help us, but it's a mix, it's a mix. Just when you're asking about tax financing, I also say it's mixed. So even in this aspect, we need the help from outside, but we also have to focus internally and see what we can do, planning better, setting the necessary business environment, being more efficient, building our skills, which I think we have, enhancing capacity every day. So thank you very much, Chair.
Thank you very much, Isabella. I agree. And Francis, you've been prompted to come back in from you.
Yes, to respond to your question, Stephen, about vaccine equity. Mm-hmm. Some years ago, I was a member of an international commission with the Secretariat at the Academy of Science in Washington, and we published a report on infectious diseases as the neglected dimension of global health security, and did make recommendations exactly around the question which you have asked. Point number one would be to say that a public health issue, a global public health issue of concern, cannot be left to market forces. And this is where we have become with this vaccine issue right now for COVID. There are instruments and institutions at WHO which were set up to deal exactly with this type of situation, but they are not influential enough to achieve their goals. So back again to the question is, do we care for each other, the partnerships and so on? We need governments from both the South and the North to stand up to this common good, to this common public goods agenda. And great to hear that President Biden has supported the waiver of the patent. And we need more of that if we are going to survive future pandemics, which are for sure going to come even worse than the current COVID. Then Isabella talked about what Africa is doing to get some independence on this issue and self-sufficiency. Yeah, this is an agenda which has been talked about, but again, our leaders are busy building dams and bridges and those type of things. And this topic is now coming to them. It is there, but they are going to forget about it again soon. So the message I conclude with is the same that I started with. We need a global campaign to put health in Africa where it belongs as the purpose of all SDGs. And this campaign is one which we from the South cannot wage successfully alone. Thank you.
Well, thank you very much, Francis. And unless anybody else puts their hand up now, I'm going to seek to draw this webinar to a close. People have referred to Davos. Well, of course, Davos is really redundant these days because we've just proved that we can have an hour-and-a-half conversation without needing to leave our office, never mind get in a private jet. And frankly, a richer and better informed conversation, at least about healthcare, than anything I suspect that's taken place in Davos. For me, the takeaway from this conversation is to reinforce what I said a moment ago, that I strongly believe, most obviously in the context of the pandemic, there is no solution to COVID that makes one country safe without making all countries safe, for the blindingly obvious reason that the virus crosses national frontiers. So without global security against the virus, there is no security. But that's only a tiny example of a much bigger point, which is that health is both part of our common interest in economic development and part of the shared experience that all of us have as human beings, that again, not merely in a COVID sense, but in a much broader sense, we don't live secure lives if our neighbor can't live a secure life as well. And so that's the purpose in my mind of these kind of exchanges. It's indeed, in fairness, the purpose of the Davos exchange as well, although it's an exchange between people from a rather narrow catchment community. This has been a much better discussion than that. Thank you very much to everyone for participating in it. And thank you to Steve Gardner and World Healthcare Festival for bringing us together and making it possible. Thank you very much for joining us. I'm going to hand us back to Steve now.
And thank you very much, Stephen, for wrangling a large and diverse and thoroughly fascinating panel. Never easy with a group of this size, particularly a group of this size with such absolutely fantastic insight. I really can't thank you guys enough. So much content, so much to reflect upon, so much that I've learned, and I'm sure our audience have learned as well. Apologies to those people who were posing questions in the chat. I think Stephen was trying desperately to squeeze your questions in, but there was so much to be said and so much to be heard from our brilliant panel that we couldn't manage it. So thanks again for this morning. Thanks to all of the panelists. Join us again tomorrow. Tomorrow we have our session on the role of the UK NHS in global markets, for which I'm very pleased to say we'll be welcoming Stephen back as our chair once again. That's at 10 o'clock tomorrow morning. If you haven't signed up, please do. And I'll see you again very soon. Anybody who wants to watch this back, it will be available on the website for the next few months, so you can watch it all back again if there were bits that you wanted to pick up on. And please feel free to email me, get in touch with us here at Healthcare World if you'd like to contribute to both this and future debate. Thanks very much once again, panel. That was absolutely fantastic. I'll see you all again very soon. Thanks.